Registrar in Community Medicine, MOH Office, Ratmalana. She will speak to you on indeterminate leprosy with background hypersensitivity, contact, surveillance and care continuity lessons from Ratmalana. Over to Dr. Gunarjan.
Good afternoon, dear all. On behalf of the team of MOH Ratmalana, I will be presenting our case study on indeterminate leprosy with daclazone hypersensitivity. In the public health perspective, we classified leprosy as a neglected tropical disease, and we all know it's curable with multi-drug treatment. Around the world, there are more than 120 countries with high prevalence of leprosy, reporting 200,000 odd new cases per year. Among these, majority of the annual new cases are from the Southeast Asian region, and in the Sri Lankan context, even though it's low endemic country, but there are persistent leprosy cases with sporadic household clusters. And in 2022, according to the leprosy campaign, there are 194 new cases in Colombo district, and in this year, there are 8 leprosy cases in Ratmalana and MOH area. In Sri Lankan context, we mainly classify the leprosy for the treatment as bacillary, multibacillary, and there is a middle category called indeterminate, and it is a clinical diagnosis, and along with that, the dermatologists initiate the postbacillary or multibacillary treatment regime. And when consider the case study of our client, it's a 32-year-old professional who is mother of a 3-year-old child who has seeked the care early, but the course was complex due to the daclazone hypersensitivity. And this is the timeline of the clinical course. In January 2025, there is an accidental heart fragment fracture detection, and sought the care within 1 week of detection of the patch. And in January and March, the patient has undergone 2 biopsies, which became as inconclusive with the clinical diagnosis of indeterminate leprosy. She was started on postbacillary regime and including the daclazone. In April 2025, the patient has developed severe daclazone hypersensitivity reaction, which warrants MICU admission, where the H544 notification form has been sent, and that's the place where we encountered the patient. Thereafter, she had relapses during the steroid tapering, and there were extensive investigations, including genetic testing of HLA-D13. In daclazone hypersensitive reaction, as you all know, it's a severe drug reaction, which typically begins 6 to 6 weeks after the initiation of daclazone, where our patient has developed this clinical classical triad with the eye fever, widespread rash, and there also hepatitis was detected, and that's what she needs warrants the MICU admission. Regarding the public health action we initiated, once we received the notification, there is a home visit and contact tracing, along with the stigma-sensitive counseling and the referral check technique. As this is a single case study, we utilize the data from clinical records, investigation reports of the patient, PHI field notes, and when considered the timeliness of the clinical events, the seeking of the medical care, receiving of the treatment, receipt of the notification, and notification sent from the hospital, and the contact tracing. And timeliness and coverage and continuity was assessed as indicators. Verbal consent was obtained from the client and the family for the anonymous reporting, and the routine program data was used. As you all know, once we received the notification regarding notifiable disease from a hospital, which is from the H544 form, we do several investigations and several reportings. At the end, there's a special registry at the MOH offices where each patient details is recorded along with the contact following our field visit. So regarding the results, the notifications sent from the MIC to public health authorities, but there's a considerable period where the gap was a little bit high, and the registration with the dermatologic clinic and the structured research follow-up need to be initiated properly. And as a public health team, we conducted the home visit, and the detailed contact histories was obtained with routine surveillance initiation. At the first encounter, we were able to screen 4 households and along with the stigma-sensitive counseling, following which we obtained the positive feedback from the households, which was positive. And these are some indicators for the case study. Regarding the lessons learned, one unique thing regarding this case is this case is not reported from the routine low socioeconomic status, and this client is well educated, and the client was known and has to seek the medical care early, but there is some gap because as we think the client is educated and know how to go beyond this, the proper tracking from the curative sector has not been implemented, assuming that the good level education people know the proper pathway, so we need to bridge those. Along with that, the MIC notification and the outpatient notification has to be strengthened. Sometimes that harm-sensitive reaction can interrupt the therapy and increase the risk of poor outcome. Integrating the stigma reduction along with the district communication and stigma-sensitive family counseling seems to be very effective in this case. Following that, we also emphasize that there should be a time-to-time capacity building for the field staff for early recognition of the disease. And this is the first encounter of our MOH staff of a client who had a genetic testing for the Dastone hypersensitivity. And field staff might be asked regarding this during our field investigation as well. So because of this interesting genetic reporting, we further explored regarding this HLA B13 and Dastone hypersensitivity. And these are the few literature we found during our research. And there's a study done in China where they have strong association with Dastone hypersensitivity, reported with sensitivity of 85% and specificity of again 80.7. And there's another case control study has been done in India, also depicted very high odds ratio of Dastone hypersensitivity with association of the HLA-D13 gene. And even in Indonesia also, from both those studies, they have recommended some pre-treatment screening if there's a screening is feasible. Some systematic review also has been explored regarding this, and it depicted in European and African population there are 0% of HLA-D gene. It's more common in South and East Asian region population. And there's one study in Sri Lanka, it's also depicted, it's a case report. There's some association of HLA-D13 with the Dastone hypersensitivity. So these are the lessons learned, and this is the, as I told before, this is the first encounter of a patient with a high economic class with leprosy for our MOH, and the genetic testing being done for the Dastone hypersensitivity. Thank you very much.
Thank you for that interesting presentation. We have time for one or two questions.
have one question. How much does it cost for HLA?
Actually, we have asked regarding that also. It was not done from the outside. It was done as a study from the Faculty of Medicine in Stockholm, free of charge for the patient.
There is an ongoing study with the NHS Colombo South Teaching Hospital and CLC, where Faculty of Medicine Colombo Pharmacology Department is conducting this research as a pilot study to see whether patients with dapsone hypersensitivity in Sri Lankan patients, whether they actually have the HLA-beta-D1, whether it is prevalent in Sri Lankan patients. If we can actually prove that association, later we may need to use this as a recommendation for screening in our patients in order to prevent dapsone hypersensitivity.
Thank you for that valuable input, Dr. Indira.
Just to add Indira's talking. Indira, so now we have some, even in indeterminate leprosy, sometimes we can't confirm the diagnosis with biopsy. And also neural leprosy is the same issue. So for those patients at least, we have this facility. Then we are not exposing these patients to unnecessary side effects of that sort. There are some patients. We only start anti-leprosy treatment online based on our clinical judgment. Those cases at least, this test should be available.
Yes, actually, that was one point I also wanted to make. Even here, the diagnosis was indeterminate leprosy. And the diagnosis was made in a very short period, and it's an indeterminate leprosy, and the patient going into severe dapsone hypersensitivity syndrome, where the patient's life was at danger. So, yes, your point is well taken. I think we should at least think about this. Yes.
Thank you.
Thank you.
Our next speaker is